pleasure for me to invite strabismic services and in charge of low vision services Arvind Eye Hospital Tirunelveli. Mentor to umpteen students both inside and outside the country, I would describe Dr. Fathima as an elegant blend of being an authority in the subject and an embodiment of powerful silence and humility which every student in Arvind would vouchsafe. Thank you for being with us, madam. Over to you.
Very good morning to you all. Thank you, Dr. Samyukta, for this wonderful opportunity and KSOS. Till now we have listened to excellent talks about all the aspects of NSBSVA. So we will go into different case scenarios. First of all, I like to emphasize the divergence disorder and accommodation disorder has a close link, everybody knows. One can induce another, one can occur as a compensation for another disorder, or both even associates, like coexist. So we will see, the first one is I like to deal with this convergence insufficiency. As Dr. Mallika mentioned, convergence insufficiency is the commonest in SBSVA. So in this case, one 15-year-old Ria, actually these are not real patient's name, I have changed it, complaining of eye strain after 10 minutes of reading, 15-year 10th grade student. Imagine the distress the patient has. So she had the findings suggestive of convergence insufficiency. So if we stop up to it, we will not be able to find out this data. When we worked upon the accommodation status of the patient, we were able to find out she had accommodation insufficiency too, because he was able to not able to stimulate accommodation, lack of accommodation, so on. So what is here is the primary disorder is accommodation dysfunction, insufficiency, which leads on to which source, because of that the amount of near exophoria increases and the positive fusion vergence value decreases. It is not actual convergence insufficiency, it is pseudo. This patient needed an instant relief. This patient will not wait for vision therapy, and particularly 10th and 12th grade patient, we cannot convince them for office-based therapy. In Tamil Nadu, I hope that may be true in Kerala also, because the reading is their primary motto. So near add, minimum add was given to the patient and along with vision therapy. Vision therapy should always include positive fusional vergence strengthening also. Even though it is pseudo-convergence insufficiency, we have seen patient coming back with double vision, decompensated fovea. And also we have informed her that she may need prism in future if she doesn't do accommodation, if she doesn't do exercise properly. One-way safeguarding, happily we can prescribe if the patient comes back with decompensated fovea. So few words about accommodation insufficiency. Like for all other conditions, we have to treat small, even whatever small refractive error, whether even if it is minus cylinder, we have to give. And if there is associated esophoria, we can comfortably prescribe NIRAD. If it is associated exophoria, we will add, we have to add with fusion exercise. And young children, we can really encourage them to undergo office-based vision therapy and see improvement in accommodation. Unlike fusion insufficiency, accommodating insufficiency, does not really respond well to vision therapy. It needs more dedication and involvement from the patient side. So here comes the case 2, where 11-year-old Biju complaining of eye strain with reading, again same complaint. And always we have to include the systemic illness history and systemic medicine history, as the previous speaker pointed out, to rule out the other systemic illness. And here if we see, there is the findings of convergence insufficiency. But if you look at the accommodation excess data, the NPA is normal. If you stop up to this, you will not find out these data. So the facility testing at least should be included even in high volume OPD. So particularly monocular accommodation facility. Binocular accommodation facility will be very much influenced by the vergence disorder. If vergence disorder is there, you will naturally get binocular accommodation facility values also will be affected. So here MAF also shows 0 and fails to relax and findings of accommodation excess. And if you look at the refractive error, it is minus before in dynamic and plus in cycloplegic, so pseudo-myopia-like condition. So convergence insufficiency with accommodation excess. So what has happened here is accommodation excess has occurred as a matter of compensation. To compensate the insufficiency, accommodative convergence has come into place. So the patient has over-accommodated and ended up in accommodation excess. So we have to concentrate both the aspects in our vision therapy. Patient underwent 2 weeks vision therapy and recovered well. So up to now what we have learned is convergence in CI can be associated with normal accommodation or excess as a compensatory mechanism. If it is with weakness, it may be of pseudo-convergence insufficiency. So coming to few excess cases, because nowadays we see more excess cases in this digital usage era. Case 1, 13 years, 8th grade. Here a typical case of variable reflex, more minus in dynamic and in cycloplegic very less minus, and a patient was diagnosed to have pseudomyopia. Patient was being treated elsewhere with the progressive addition lens and plus 3 diopter. Even then she was somehow not convinced and comfortable with the treatment, so she stopped the treatment and came to us. Actually she visited Madurai Aravind, so where they treated her with office-based exercise, modified Boris delayed subjective testing technique for 8 sittings. The symptoms resolved completely, so patient was very happy. I like to thank Dr. Shetty sir, Chief of Pediatric, and Ms. Janani, optometrist in Madurai Aravind Hospital, for sharing this success story to us, so that we have also started this technique in our vision therapy. Coming to, let me describe the technique in little later in my slides, and coming to second case of accommodation excess. This child, 9-year-old, presented to us with intermittent inward squinting. So similar episodes were there before, and there was no history of prolonged mobile phone usage. Usually it will be associated, but here no usage, no mobile phone usage. Refraction was completely normal. And here if you see the data, the patient at once, when you saw the target, the patient will go for esotropia, that too large angle, 45% diopter esotropia. And if we look at the accommodation values, it is towards excess, minus 5.5, and a high lead of accommodation. So what is here? Here with cycloplegic refraction, we were able to note down that there was +1 diopter refractor correction, so we prescribed him with the correction and vision therapy. And 2 weeks later, but he came back. So this time we have engaged him in office-based therapy for 12 sittings. With 12 sittings he recovered very well, but again to our surprise he came back within 1 week that the condition recurred. That time the mother revealed to us, earlier we were probing her any precipitating factor like that, the history we were asking, but we were not able to elicit from her. But this time she was able to pinpoint that whenever that her husband is a drunkard, so that fighting argument goes on, he goes into kind of such distress, stress, and manifest this. So definitely the important causative factor has to be addressed. So we arranged for parents counseling, and also nowadays we see many patients, many children who are under psychiatry treatment showing accommodation excess. So that part has to be considered, and proper referral to psychiatrist in case whenever necessary has to be done. So what is modified Boris delay technique we follow? It includes 2 phases. It is clearly described in this article by LVPI. So in the distance phase, we make the patient to wear strong fogging lens. That is, we include the normal NRA value plus 2.5 plus cycloplegic refraction value. This patient, for him it is 3.5. So we put 3.5 on both eyes and ask him to read a storybook for 30 minutes. Initially, excess patient will read keeping the book close to them. We will encourage them to push the book backward, longer as far as possible, at least 30 centimeter, 35 centimeter at the end of 30 minutes. So by the time the patient will relax the accommodation, and then we will make defogging for distance, 6/9 target, and we slowly defog with minus lens. So the patient is relaxed, patient's accommodation is relaxed for distance. Now the near phase is done. Near phase is nothing but like performing NRA testing monocularly. Since because we does monocular, the fusional loop is removed, we concentrate more in accommodation part. what we do is this accommodation phase, we gradually add plus lens till the patient relax completely, then we can induce accommodation. Maybe inducing accommodation we can withhold for initial few days. We can aim only relaxation in the initial days, then we can move on to stimulation also. So similar procedure is done in other eye. And here comes our PG NEET aspirant. You can imagine the status of the patient's eyes. So his complaint is double vision for past 2 weeks, particularly for distance, and onset was associated with fever. MRI taken was normal, and refraction absolutely, dynamic refraction was fine. So when we worked up with binocular status, we were able to find out distance esophoria 4 prism diopter. So kind of divergence insufficiency. But when we look into the accommodation data, he showed excess. Though MEM value is normal, MEM value also depends upon who the person who performs. It should be done in a swift manner, fastly. The procedure should be correct. Otherwise, the value. So we have to correlate. Always, we have to correlate more than one value to conclude the diagnosis. When we did cycloplegic refraction, we were able to pick some uncorrected hypermetropia. So what we did is we gave him that hypermetropic glasses and advised him exercise regarding accommodation excess and for divergence. To our surprise, his symptoms relieved, and also importantly the counseling about the need for break and not to use mobile phone for reading, everything has to be emphasized. Here this case says how much important is the uncorrected refractive error treatment. So what we have learned here is the very first case was accommodation excess with just pseudomyopia. Second case was accommodation excess with intermittent esotropia. And the third case, the second patient, then when he came for later visit, he presented to us with all the findings. And that NEET patient had uncorrected refractive error, and CI patient also can show accommodation excess. So counseling, nowadays there is a bad behavior in among parents regarding too many coaching classes, and from school too many homework, and from students themselves prolonged mobile phone watching, sleep deprivation, and apart from that there is many incidents of psychological stress. All have to be addressed for holistic recovery. Here is another interesting case of 13-year-old where intermittent diplopia past 2 days. As mentioned by Dr. Malika, acute presentation we should always be take into concern. BSVA will not present with acute symptoms, but here the patient was a doctor's daughter. So we thought, okay, they were anxious, they brought so quickly. What the workup showed, the refraction showed little hyperopic thing. Again here, near exophoria and distal esophoria, that is divergence insufficiency. And look at the accommodation data, everything is fine. Even the NRA is also high, we are strange. Extraocular movements full, but our ocular examination was not complete. Small people, we were not able to see the fundus. We were insisting for dilating fundus, but next day the patient had half-yearly term exam, parents were hesitating. So what we did is, we asked for evaluation because there is some foria difference. Luckily, our optometrist brought out incompetence in the foria. That too, fixing right and left were different. So now we strongly suggested either dilatation or MRI imaging has to be done. Then we found out this papilledema in that patient. And luckily it turned out to be pseudotumor cerebri and treated and recovered in 2-3 weeks. So the point here is we should never compromise complete ocular examination and never label the patient without ruling out ocular cause and systemic cause and say NSBBA, because there is a high chance to miss important things. And here is a case I wanted to show, Duane's retraction syndrome. Again, fusion problem when she has developed accommodative demand as she grows older. But here we can very well note the patient is not able to bring the eyes into the center because of the co-contraction. One eye is not at all able to converge inside. Here there is no role for fusion exercise treatment, so we straight away suggested her 4 prism adapter basin. So to conclude, thorough history taking, ocular and systemic, complete ocular examination, detailed workup, dedicated vision therapy is important for appropriate diagnosis and management of NSBB. Thank you very much. Thank you very much.